Hello, everyone. Thank you all for joining us for our first of two sessions looking at inviting HRM alumni to talk a little bit about their experiences, what they did at Mac, where they're at now, and some tips and tricks for current students. So just a few housekeeping items before we get started. If you have any questions throughout today's session, you can put them in the Q&A chat. You can also send them directly to me and I can ask our panelists on your behalf. The way today will work is each of our panelists has approximately 10 minutes and they'll share some slides. They'll talk a little bit about their journeys, what they did at Mac and where they're at now. And then we'll have a good chunk of time towards the end for questions. So please feel free to send your questions as they come, and I will be sure to ask them either to the individual panelists or to all our panelists in general. So thanks again for joining. Thank you all for including our panelists for having us today. And we're really excited. So without further ado, I'm going to introduce our first panelist, and then they know to go. So Flavia, whenever you're ready, the floor is yours.
Great. Thank you. Can you hear me okay? The eternal Zoom question. Great. So thank you so much for inviting me to be here today. My name is Flavia Bianchi. I did my master's degree in health research methodology from McMaster. I graduated in 2008. Which feels like just yesterday, but sometimes a lifetime ago. Currently, I'm a senior technical advisor at JPIGO within the School of Public Health at Johns Hopkins University in Washington, D.C. My area of focus, and it has been since McMaster, is HIV, specifically pediatric AIDS in Africa. In this role, I am, and my career has mostly focused on program implementation, and program evaluation of HIV programs in Africa. I've been in the US for 13 years now, but Mississauga is still my home. Before joining Hopkins, I was at the Elizabeth Glaser Pediatric AIDS Foundation, again, a focus on pediatric AIDS, which I have McMaster to thank for. And prior to that, I lived in Johannesburg, South Africa for almost 3 years, during a really pivotal time in the fight against AIDS when things were really changing. I ended up at McMaster very much by accident. But it was truly one of the best decisions I've ever made. I actually have 2 degrees in environmental sciences. That's where I was headed. And I started a PhD at the University of Saskatchewan, where it was very cold. Also in environmental sciences with a focus on environmental health, medical geography. And it was during that time that I realized that I wanted to do more health and maybe a little bit less environment. And so I actually left Saskatchewan and came back home to Mississauga, and I got a job at McMaster as a research assistant at the School of Medicine. And when I was hired, the wonderful Dr. Carl Stobie, who I believe is still at McMaster, hired me with for a position in research and program evaluation, and I had no experience in program evaluation. And so I said, if you hire me, I will learn everything I can about program evaluation. And that's how I really started looking at the MSc program and thinking that I would sort of go down the path of medical education and program evaluation of medical education specifically, because that's what I was doing at Mac. So I was a full-time employee and a part-time student, and it was during my time as a student that Stephen Lewis was an academic advisor, a scholar in residence. He had just finished working as a UN Special Envoy for HIV/AIDS to Africa, appointed by Kofi Annan at the UN. And I went to one of his talks on HIV and his work, and I was absolutely inspired. And so that kind of changed things for me. So I pivoted away from evaluating medical education towards HIV. And he became an informal mentor of mine. And when I was just about done school, I went to him and I asked him, what should I do next? I had wanted a career in international health and development. And he said to me, not verbatim, of course, but he said, if you want to know HIV, if you want to know AIDS, you need to go to where the problem lives. And he said, you have to go to South Africa. And so I found an internship for McMaster that, it was a requirement to go to Johannesburg. While I was there, I found a job and I moved. So I spent 3 years there working for Wits University in Johannesburg, in one of the busiest clinics in Johannesburg in research. It was like entry-level research position. But working, directly with clients, with healthcare providers. Again, sort of during a really important time in the fight against HIV, things were starting to change. Drugs were being allowed into the country after having been banned by the former president of the country. So it was like a really great time to be learning right at the forefront. And that kind of shaped things for me. I came back after 3 years to North America. I ended up in the US, first in North Carolina and then in Washington, DC. And it has been, just for me, it's been just an amazing ride with my work and my career in HIV. I'm based here in DC, but I have projects in West and Southern Africa, so I travel there quite a bit. And just like I did in Johannesburg, I'm back at the facility level. My role is primarily using data to improve the quality of services for HIV patients. And so I look at the data, I work with clients, I work with healthcare providers to assess our clients, HIV patients, getting the kind of care that they need based on the data. And if not, then it's working with the healthcare providers, the Ministry of Health, to make sure that clients get treatment on time, viral load testing on time. If there's treatment failure, that they get onto the second line regimen. So it's been, I'm forever grateful to McMaster for many reasons, just setting me up from, in terms of my degree and learning from just wonderful scholars, and also just access to just inspiring people like Stephen Lewis. There was a lot of wonderful people at McMaster that I learned from, wonderful thesis advisors. I was in a class with many physicians who sort of got me really interested in HIV as well, and what the patient experience is like. So eternally grateful to McMaster.
Wow, thank you so much, Flavie. I think your story is sort of like the epitome of, learning, answering questions as they sort of come up, and then learning from experiences and letting those guide your next steps. And it's really cool to see sort of your trajectory across the world, but also in terms of different roles and how some of the work that you did at McMaster helped shape those roles. So really fantastic. Thank you so much for sharing. And again, just an encouragement to everyone who's tuning in today to post your questions as they sort of come up. You can use the Q&A function, or you can send them to me directly. Okay, so with that, I'm gonna hand the floor over to Arya for his little spiel.
Thank you all. Great to be here virtually, and saw the Tim Hortons Cup, so which I really miss. So glad to be with you guys virtually. I'll tell you a little bit about myself. I have a few slides because I feel like I'm dependent on slides. I have to, to put my thoughts together. But I'll tell you a little bit about myself. I'm my journey. I'm at UCLA now in California. I'm a pediatric neurosurgeon, and I'll tell you a little bit about my journey and how HRM fit into my journey and career. So prior to HRM, so I'm raised in, actually was born in Iran, left when I was 2, lived in the UAE for 8 years, and then moved to Toronto when I was 10. That's where sort of I grew up. I went to Western University for my undergrad, biology, finished that in 2005. And then the only medical school I got into was McMaster. So I was quite excited about that. I tried to find a McMaster or Hamilton skyline, I should say. And this is the nicest photo I found for Hamilton's skyline. So I really enjoyed my time there as a medical student. I think Michael G. DeGroot was just brand new when I started, and remember my time there very fondly. Became interested in neurosurgery, and spent some time at McMaster there with the folks there, and finally started to do my residency at the University of Toronto, where I was there for 6 years. Now, during my time as a resident, I became very interested in these ideas of, clinical research. I mean, we had definitely a really good introduction to them, having gone to med school in McMaster, but the issues of sort of, how do you decide on different treatment approaches or medications or surgeries and so on became more interesting to me as a resident when I started taking care of patients. And I realized how, little we know, or how some folks use the data to support what they're, what they want to do anyway, and they kind of misuse data in a way, and sort of, I just became very interested in trying to find out, in this pursuit of the truth, right? Like, how do you find good data to support the care that you give to patients and making sure they're really getting good care? So what I did, I was fortunate enough at the University of Toronto, where they allowed me to take some time to get a master's, and I kind of did this concurrently. So that's sort of what led me to HRM. One of my very close friends, who was also a graduate from McMaster University, his name's Shanil Ibrahim. He went there, he did a PhD there, he spent time, I think he's on faculty as well. But he told me to look into McMaster's Health Research Methodology program, which is really world renowned. And during my time there, so I spent, so I graduated in 2013. These were my mentors. Everyone knows these faces: Dr. Gayed on the left, Dr. Bandari on the right, who are, it's hard to go through this program without having met them or work with them. There's a ton of amazing faculty, though, I should say. This is not just them, it's everyone. Dave Sackett, the late Dave Sackett, which I also spent some time with during my small tutorial groups, was a wealth of knowledge. And the people that I met there were so interested in the type of work that we did, that we could really see the excitement, right, when they would teach these things, and not only teach them, but sort of engage the students. I remember fondly just being in a small tutorial group with Dave Sackett, and he basically got us to think about why we design studies the way we do, and and sort of tapping into the way his brain worked, and sort of how they created this field, right? Like where this field came from. And the nice thing about being at McMaster is you're really learning from the pioneers, the folks that really were on the ground zero developing this, when this was just an idea, right? So I have a very fond memory of my time there, both academically as well as personally. So they were my research mentors, but also the friends that I met at McMaster, right? These are lifelong friends, met people from all over the world, folks from different backgrounds and different cultures, and it was so rich. And I still keep in touch with many of the friends I met there, and they've all gone on to great careers. And it was just such a great time for me to sort of reset and think about what I want to do academically and medicine. And a lot of the things that I learned there, I still use today. So after HRM, I did a pediatric neurosurgery fellowship at the University of Miami. And then starting 2015, I've been on faculty at UCLA. I'm now at the associate professor rank. I have appointments in neurosurgery, pediatrics, and public health. And my subspecialty area of expertise clinically and research is in pediatric epilepsy surgery. So this is, it's a very rare operation that's done in the world, that one of few people that I do is sort of, removing an entire half of a child's brain for epilepsy, which is actually a very complex operation that we do routinely. So we get families from all over the world that come for that. And to me, we do this in a way, a super invasive operation based on very little good data, right? So this was like the perfect career path for me, right? To apply everything I learned in health research methodology, clinical epidemiology, biostatistics, to sort of how do we make good decisions, right? How do we know that this is the right thing? Is there, how do we counsel patients and all that? So it really, I continue to use a lot of what I learned in HRM every day. It allowed me to have so far a good research career, been able to publish a lot of papers, travel the world, give talks. I mentor fellows, residents, students, and a lot of it I owe to sort of the skills I picked up in HRM, and really just developed a passion for research, right? That I think more than anything, that's sort of, I think, an important, if you talk to the folks that are in academics, they have that passion to sort of learn more and push themselves. So I'm not going to take too much time. I will say I am going back to school, and I'm going to be starting my MBA in 2023 here at UCLA, and I'm happy to also talk about that if you'd like, but really the focus today should be on the HRM program. Thank you.
Awesome. Thank you so much, Arya. I think it was really cool to sort of see, you talking a little bit about your interest in medicine and how you then decided to, come into HRM to learn more about how to use evidence to inform the decision making, but also, you used it to inform your area of practice and finding parallels between your research and your clinical practice, which I think is really important to discuss here, especially because a lot of students in HRM have sort of juggle those two different worlds and are probably thinking about a lot of the questions that you had at that time. So thank you so much for sharing that. Really excited to see some of those questions that students are asking. And with that, I'll pass the floor over to Anne.
All right. Well, again, thank you so much for allowing me to chat with you today and inviting me to chat with you today. I'm Anne Brundle. I'm a maternal fetal medicine specialist at Sunnybrook Hospital, which is University of Toronto. And I'm the director of the Accessible Care Pregnancy Clinic. So I'm going to also use slides. I'm also dependent on them to keep me organized and making sure that we're seeing what we need to see. So I'm just going to start out. This is a lovely picture. Can you guys see my slides? They're sharing? Yeah, perfect. One of my patients with spina bifida with her baby that she had been told that she would never be able to have. And, she was really grateful and allowed some professional photographs to be taken of her. And I just think this sort of really embodies why I do what I do, which is to help people be part of the journey of having happy families and supporting people with disabilities who maybe were told that they were not capable of doing things, or there were not possibilities that were open to them in their lives. So my educational pathway, I started at Queen's. Mine isn't quite as pretty. I should have got some nice pictures of all the lovely universities that I've been to. So I started at Queen's, and then I did also do my MD at McMaster. And then I went to Dalhousie, where I got my FRCSC in obstetrics. So that was general obstetrics. And then after that, I came back to McMaster to do my fellowship in high-risk obstetric, which is maternal fetal medicine. During this time, I met an amazing mentor named Sarah McDonald, who is also a maternal fetal medicine specialist and is highly involved in the HRM program at McMaster. And I started chatting with her a lot about research and about how can we do better. There's so much in obstetrics that is unknown. There's so much in obstetrics that people are afraid to look into. People are afraid to do trials on. And in the end, the people who lose out by not having adequate research are the people who are pregnant and their children, because we don't have access to good information to guide us. And this really hit home for me, especially when I was focusing on high-risk patients. The stakes were high for both their lives and their children's lives during their pregnancies. So during my fellowship, when I was pregnant with my second child, I decided I was going to apply to HRM under the mentorship and guidance of Sarah McDonald. And I got into the program, and I started 10 weeks after I had my baby, because I suddenly became very interested in trying to complete the 2-year master's in 1 year and complete my fellowship that year and have a newborn. So it was a very, very nutty year. And when I look back on it, I kind of can't believe that occurred. But really, it was really facilitated by the outstanding mentorship and facilitation that happened, both from my fellowship program in terms of aligning my rotations, being able to start my program early in the summertime. So I got some of the courses out of the way during that time. And it was a little bit more flexible than being in fellowship in terms of the timing. There was on more than one occasion that I showed up to class with my baby. And everyone was super supportive and passed her around. And, I just was really blown away by the camaraderie when I was in this, sort of really tight situation, trying to accomplish all of these things in one go. But the support from both my mentor, Sarah McDonald, the other students in the class who I think thought it was a bit of a novelty and a little bit fun, but also we're very supportive to have a baby passed around while we're all doing our final presentations at the end of a course, was really, really wonderful. Probably one of the most influential things that I learned, apart from working with such amazing people, again, from all over the world with such great perspectives, is that everyone cared so much about the population they were interested in learning more about. And Dr. McDonald really hammered home for me the sense that whatever we're studying, we need to do it to improve the lives of pregnant people and their children. So whatever you're picking to do, whatever you're passionate about, think really carefully about your clinical question. Is this worth spending your time on? Huge amounts of effort, huge amounts of resources, if you're not going to be able to make clinical change for a population that matters. So I think by really getting this overview and this ethos of how we should be conducting research and why we should be conducting research was extremely influential to me for the rest of my life. So after this super nutty year, I was hired at Sunnybrook as maternal fetal medicine staff here and assistant professorship. And so now I spend a lot of time, I do 40% research and a lot of time also training other residents. So because I'm an obstetrician, I have to show pictures of babies. You can't escape it. It's going to come up in any presentation. So this is me having a great day. And this is actually a really important photograph that was allowed to be shared, because this is one of our accessible care patients who needed to have a general anesthesia during her surgery. So she was not able to be intubated. And a big piece of what we've learned from surveying people with physical disabilities who are pregnant, from really trying to get good information from a patient-centered concept, is that when people need to have a general anesthesia, they want birth photos, and this is just part of having that patient-centered care. So we really focus on making sure we get good pictures. So it's still a birthday party. This is a happy event. This is a joyous event, even though this is a highly medicalized event for safety reasons. Other things that I get to do during my day, I'm pretty lucky. I get to do a lot of different things. If my slide is just going to move forward, my pictures are so big, so I get to do a lot of ultrasound. I get to work with a lot of amazing teams, so like a lot of that complex team planning. I get to photobomb families celebrating their children. It's a really lovely and varied experience. This is one of the patients who had 2 children with us. And this is right at the beginning of the development of a whole clinic, the Accessible Care Pregnancy Clinic, specifically for people with physical disabilities. And I used a lot of the skill sets that were developed during HRM in terms of this patient-centered focus. And, you know, whatever we do it with the patient at the center of all of our concepts. And this is the first clinic of its kind in North America. We used focus groups early on to learn about what people wanted in terms of a clinic. People from the community of people with disabilities. We looked at different accessibility resource centers who also provided input to us. And one of the key things that came across from doing this initial sort of surveying of the land is that people need personalized medicine solutions. People with disabilities do not want to be all grouped together. There are a million different reasons why someone might have a physical disability, and the way that it impacts them is totally different during pregnancy. So although there are general concepts regarding respect, making sure that areas are accessible for a person physically, the medical aspects are quite different from person to person. My final project with the HRM was actually looking at survey design, and surveys, you know, are sort of the lowest common denominator of research areas. You know, it's considered, you know, fairly low quality, but when you're trying to access a rare population, sometimes it's the only way to really get good data. So we've launched a series of international online surveys looking at people with specific types of physical disabilities to get large sample sizes about their pregnancy experiences, outcomes, and complications. So all of these people that you see here have a different reason for having a disability and would have a different medical plan that's individualized to those people. So through research, we're able to provide individual care plans. This is just a slide sort of showing where we come from with this. We've been able to write some national guidelines, both specifically for spina bifida, but also for the care of people with disabilities in labor and during birth. I get to do a lot of amazing teaching. So that's me with one of my fellows with one of our quite fragile accessibility patients. And I just appreciate, you know, every day being able to work with such amazing, complex, interdisciplinary teams. I'm happy to take questions at the end as well, of course, about this that I'm so passionate about.
Thank you so much, Anne. Just hearing you speak about the work you do, sort of the passion bleeds through, so it's great to see. And I mean, belated congratulations on that. You're just even describing all the things that you were juggling at that time is amazing to me, and really puts into perspective what you can do with good support and strong mentors. So congratulations on that as well.
Thank you. I would recommend it to anyone. It was like a weird clash up of life. I'm not saying this is a life, but there were wonderful people around me. So
good disclosure to have. Thanks for that. All right. And then with that said, last but certainly not least, I'm going to hand the floor over to Ananya.
Perfect. So I've decided to use slides as well, but I'd love to just share my story about my life after HRM and where I'm at now in my career, and understanding through my journey valuing a teaching stream faculty position. I'm also going to share things I wish I had known when I was, you know, pursuing my HRM degree as well. And so in terms of a personal academic timeline, in 2004, I went to York University because my dad told me he did not want me to leave home. So I wanted to stay close to him. Bought me a car so I can transport back and forth. But I think he was scared for me to live in residence and party and maybe do things that he didn't want to imagine. Okay, so negotiated again and said, okay, if you want to do your master's, continue to stay in Toronto. I was like, all right. So I went to the University of Toronto. I did my master's in exercise sciences. During this time in my master's, I was doing a lot of work looking at South Asian health inequities, focused on diabetes prevalence, access to cardiac rehab. I was also working as a registered kinesiologist at Women's College Hospital in their cardiac rehab program. So I've been very lucky to engage in clinical care for about 11 years. And then during my master's, I actually started to really enjoy research. And so I was very fortunate enough to get into the PhD program in health research methodology. during my master's, I should say I was trained primarily in qualitative research. And I was trained primarily under Dr. Sonia Anand, Dr. Michael Boyle, and Dr. Mark Oremus. And they collectively had told me that I had to train in epidemiology in order to be part of this program, which was actually a very scary thought because I was very pro qualitative research. I love storytelling, but it was actually the best decision I had made in my life to train in clinical and social epidemiology. Because what really ended up happening is that I was able to actually bring a lot of value to qualitative research among my peers, among my instructors, when I had decided I actually wanted to merge my training at the master's level and at the PhD level, and really come out as a mixed methods researcher. And you can imagine at 2012, there was not a lot of mixed methods research going on. I can imagine many of my colleagues here can imagine during their HRM time, it was a very post-positivist training. It's very numbers oriented, and qualitative research was actually not part of the HRM culture at that time. And my committee even struggled with my project when it came to the qualitative piece. But it was a wonderful learning experience. I fostered so many great friendships. Stayed up late quite a bit, trying to learn all the different models, learn how to use SAS, and so forth. And at one point I thought, what am I doing with all these data? This is not what I'm meant to be, but I persevered, and I graduated. And then I decided to continue doing mixed methods work, and I ended up getting a CHR postdoctoral fellowship at Women's College Research Institute, which was really nice to come back as a researcher, given that I worked there clinically for so long. And I was very fortunate enough to receive my first academic appointment at the University of Toronto as an assistant professor. And very early in my career, I would not recommend this now, is actually have a very strong leadership role. So I was the Masters of Public Health, Health Promotion Program Director as well. During this time, what I really realized is when I was teaching various different courses, particularly on methods, health promotion, and is that I actually didn't realize I didn't get a strong equity foundation during my time at HRM. And that was okay. I think the methods skill set that I had was tremendous. But I thought it was really important to start instilling the next generation of students, such as many of you, all of you here, who aspire to go into academia, into medicine, or become a clinician scientist, work in public health, global health, to really foster equity in our methods and public health curriculum. And then I'll be honest, it was time for me to leave Toronto, and luckily, I got a position that I really wanted because it was very teaching focused. And that's where I am currently assistant professor in the Equity, Diversity, Inclusion, and Anti-Racism lead. So based on my training, I really had a personal debate and struggle. I didn't realize that if you decide to go into academia, that there is the option of having a teaching stream. It's not as prevalent, and there's not as many opportunities as research tenure track positions. But the one thing I realized is I loved teaching during my time at U of T, and I realized I can teach all day and especially about equity and social justice to students. And I loved research too. Like, can you imagine? I trained at HRM. Am I going to neglect research? But I think my calling was really in the classroom, and I also didn't want to do research. And this is just me personally, for the sake of doing it to get published and to continue getting grants. And so when it came to teaching, I really had to make a hard decision. Is my primary focus in academia to promote public health knowledge, foster and promote critical thinking, cultivate social justice and health equity? Or is it, again, to just apply for funding, publish, really garner the reputation of top institutions like U of T. And I had decided that I really wanted a teaching stream position. I was very lucky one had come out at McGill that fit exactly my portfolio. And so I intentionally did not want to go down the research tenure track route. And I also realized during the pandemic, which is the time I started at McGill, that there's more than ever we needed to start training our students in public health, medicine, and graduate programs that are research intensive, that social justice needs to be central. And so from that, where I'm at now is I absolutely love my teaching stream position. So I teach 4 courses a year, so it's 50% of my appointment. I teach a course on health promotion, mixed methods, racism and health, epidemiology, so definitely using my skills from HRM. But that's 50%, as I said, of my academic workload. And then research is actually 25%. And I get to apply for grants whenever I want. I get to do projects that are meaningful to me and to the communities that I work with, because I do foster a lot of community engagement and health equity in my program of research, which is called the South Asian Health Research Hub. And service, because I started so early in my career in a leadership role, it almost felt weird to not be in a leadership role, and to really leverage the power that I had in an institution to really make meaningful transformational change, especially making changes in the sense that I really wanted to see equity and social justice more threaded in our education systems at the university. And so many people ask, why teaching stream? You're easily, competitive for a research tenure track position. And this was a piece I just recently published in the Lancet. And I realized that the training that often we all get really and actually forces us to uphold white supremacy and the institutions that we're part of. And I do believe that we weren't taught equity and about social justice in a meaningful way during our time. And all of a sudden, all of us are catching up to learn and trying to figure out how to be inclusive, whether it's respect to race, sexuality, disability, gender, and so forth. And we're really trying to also figure out who is missing in academia, whether it's faculty and students. And so I also have been inspired by Tori Morrison. And this is a message I really wanted to bring to my students, which I felt I've been able to do if I teach a comprehensive set of courses on methods and bring that strong equity lens in, is to remind our students that you are all so brilliantly trained in institutions like McMaster, but your real job is that if you are free, that you need to free somebody else. And if you have some power, then it is your duty to empower somebody else, whether it's through clinical research, advocacy, or service work. And one thing I just do want to share, because of my role as a woman of color in academia, to this day, I still have students saying, you are the first woman of color I've been taught by, Anania. And so I realized that I had to continue doing research and actually really do research to give economic opportunities, particularly for racialized students who have never really seen themselves in the curriculum and often the research that they see as being pursued in academia. And so I realized the power I had as a racialized faculty was to extensively work with and mentor racialized students in a very progressive and contemporary way to support their academic and career development. And so for a lot of students who've taken my courses, I have been actually able to take a lot of their assignments that are very powerful and work with them and be listed as a co-investigator, whereas I'm listed as a principal investigator, but actually get their projects funded through Tri-Council funding. Because when we think about community-based research, we have to realize that our students are part of these communities who have the lived experiences of marginality and often know what the right research questions need to be pursued. And so just to wrap up, the reason I chose to do a teaching stream is to make research teaching very personally relevant and inclusive, to really center critical social issues, to really also enable collaborative inclusive learning that includes allyship, making sure students feel empowered as community researchers, creating economic opportunities, and sharing new understandings of the data, especially epidemiologic data, bridging that with qualitative data, and lastly, to really address power and privilege in research. Thank you. And yeah, these students are the center of my career. Thanks.
Fantastic. Thank you so much, Ananya. Just listening to you speak, I mean, I would love for you to go on and would love to hear more about the work that you do, you know, grappling with the methods question and then, you know, the teaching versus research, but really the way you answer that question, applying an equity and diversity lens and highlighting that for everyone here today is such an important message. And I'm so glad that you were here to share it. So thank you very much for that. And so with that, we've sort of wrapped up the larger portion of today's session where, you know, each of you had the opportunity to talk us through some really fantastic career trajectories, all very different, but a lot of the same underlying themes. And so if you haven't already, please post your questions in the Q&A, or you can send them to me directly. And we'll spend the next, you know, 20-ish minutes trying to address as many of them as we possibly can. And so I'll start with one question in the chat, and this is to any one of our panelists, so feel free to jump in as you see fit. But how do you sort of balance your clinical career and research? And for those of you who don't have a clinical practice, you know, how do you juggle all the different responsibilities, your different roles? Each of you have sort of spoken to those roles and those opportunities that you're responsible for, but how do you sort of juggle that as a trainee, but also now in your current roles?
I'm happy to start on that if that's okay. I think the piece that I really see is that I'm fortunate that the patient population that I'm caring for is also the topic of my research, and the inspiration from what I see people facing as clinical challenges is really what then triggers research questions. So interacting with pregnant people with physical disabilities, them telling me what the concerns are, where they're at, what they've come up against, what they wish was done better, what they like that's being done, really helps to tailor good clinical questions and to sort of pursue the correct questions. So they integrate quite a bit on that end. From a timing perspective, it's challenging. In the end, if you're in a research meeting and there is a clinical emergency, that the care always will come first. So it does help to sometimes have protected time where that you don't have clinical responsibilities, and so trying to block off specific times, making meeting times are really, really important, so that when you're meeting with students and trying to really protect those and keep them as sacred is important, and then also being flexible in terms of that timing does tend to help. So they complement each other so immensely, and it is a challenge, because in the end, if someone is having an emergent scenario, then that is going to take precedent. I'm also lucky I work with an extremely supportive team. The high-risk team here is really, really good. And so whatever you do in your life, get a good team of people behind you, because regardless of where you're at, that is going to hold you up, and you will keep each other going and support each other. And we also are, we're quite close, and we know that we're all trying to balance these different things. And so we can always text someone, call someone, can you cover me even for the next 45 minutes? I got to get through this. Can you, make sure if there's an emergency here, they'll page you instead of me. And so we really do this all for each other. So I think the team aspect, wherever you go, whatever you do, surround yourself, if you can, by wonderful people. It changes everything.
I can add to that as well a little bit. So I think it's interesting, right? Because the research you do when you're a student, or you're primarily doing the work, is kind of different than when you're, I guess, the supervisor. I don't even know how to use SPSS anymore. I don't have the softwares. It's been a few years. So now I'm more of a sort of mentorship research role, and the balance is different, right? Because when I was a student, I was the type of student that would sort of finish everything. I'd be always waiting for my supervisor to sort of, what do I do next? And now it's different. It's a different challenge, as you said, balancing clinical needs versus research. To me, it's also it goes hand in hand, right? I don't really, personally, I mean, everyone has a different approach. For me, I don't separate it out. The operating room I work at is my research laboratory. That's where I obtain a lot of data. It sort of fits nicely, and but I do have, you know, we do a lot of international collaboration, and I've done a lot of meetings at 4 a.m. And like 10 p.m. and that's sort of the way the world's going now, right? So especially with clinical research, especially with what I do, which is so rare, that I got to work globally. And some of those lines are blurred. I think the other important balance is your personal life, and sort of, so career and research to me are sort of in the same bucket, but trying to protect your time as much as possible. And I think you need to actively think about, when I started, I would say yes to everything. And now I try to say my default's no, and I'll selectively say yes to things, and just to be able to protect my own time.
Okay, awesome. Thank you so much for sort of describing some of the challenges. I think regardless of what you're doing, whether it's balancing clinical versus research versus teaching, or any other responsibilities, just the importance of sort of identifying your why, making sure you have a strong team around you, and things like that. So thank you both for sharing that. The next question I see, and often I hear, especially from junior students, is around, you know, how do you figure out what it is you're interested in? Each of you, you know, in just describing your pathways, are so passionate about what it is you research or study, or the population that you work with. But how did you sort of determine that area of interest? What was it that sort of sparked that niche topic that you were so passionate about?
I mean, I'm happy to start off. I think from, you know, an equity lens, I think really where I am today is just really critically thinking about, you know, my training and things I wish I was taught versus not. But I think, you know, the aha moment for me and for a lot of people who decided to pursue a PhD is, you know, I think many of us are being trained in the sense, like, you know, you need that research tenure track degree, you need to be that clinician scientist, right? And we don't actually have opportunities to think of like alternative pathways, even within academia. I think a lot of us, you know, want to stay in the university setting, but we almost feel like it has to be very research intensive. And so I think I wish I'd known earlier about the teaching stream opportunities in the university. I didn't know that, but also seeing the struggles of my own professors when it came to like teaching, when they like had a strong clinical and research portfolio. And, you know, students notice when you put in time and effort into your slides. And, you know, most people really balanced it well. But I also came to realize if I really wanted to teach well, especially about social justice and equity, I need dedicated time to that, because like the world of equity and our world is changing rapidly every second, especially after George Floyd's death and the pandemic, and like how inequities just became so prominent. And especially now, you know, equity is like being centered in everything, even in our grants for CIHR, like there's now an EDI section. And like, how do we thoughtfully train our students, right, when to think about equity in their research, or, you know, any other you know, or their clinical care and so forth. And so I think just my presence in the classroom, like I didn't realize the impact it had for students, especially again, as a woman of color, and for people to actually see themselves like in a position like I am, like that is also very powerful for me. So when we think about representation, it really begins in education and in front of the classroom.
I'm happy to also answer that question. I didn't put this on my timeline, but I used to work at the Ontario Science Centre. I was one of those people who was like, look, you can make paper out of elephant poo, and, you know, I'm going to take out a nature walk and this kind of stuff. And the ethos of the Science Centre is a phenomenal place where there really is a focus on this intersection of science and society. And it's really drilled into you from when you're working there, that the purpose of all of this, you know, the purpose of science and learning and education, it goes nowhere without connecting with other people who will then become passionate about it and then move forward and be inspired and and do something. So it's really about that transition between people and science. So that was a really important part of my life. And then later on, I worked at a foster home for kids with physical disabilities. And so I spent a significant amount of time there. And I think it just was a very sort of eye-opening experience in that, you might think, oh, this is something, I guess you might need a ramp if you have a wheelchair, you have sort of like a concept of what that might, be about. But I think that, being, exposed and integrated, into that experience, and people sort of willing to share what they were experiencing with me in terms of it's not just about equipment, it's about perceptions, and it's about how people treat you when you go places, and it's about, there's some complex medical stuff, and then there's complex family stuff that all sort of blends into that. That also was extremely influential for me. And also seeing how often people with physical disabilities in childhood, there are more resources and sort of coordinated programs that are there. But then, people with disabilities who are kids grow up to be grown-ups with disabilities who want to go on and do normal human being things like have a family and get married and do stuff. And, it was this wonderful integration of saying, well, I kind of get that, I have a sense of that this might be a really important area, and that, by seeing where people were at and what my skill set was at, I thought this is a population that I might be able to use that skill set to help, people achieve their family goals. So I think those two experiences were quite influential for me.
Okay, awesome. And then I've got one more big question before we jump into some quicker questions, hopefully, if time permits. But one of our students is asking for anyone who's done a postdoc or any training following HRM, what was the usefulness of that? How did you make the decision to do a postdoc? And maybe I'll turn that to you, Ananya, first, because you had talked a little bit about that fellowship following your PhD.
I highly recommend a postdoc, especially it's an amazing transitional period from going from a PhD student to an independent investigator. So what I loved about my postdoc is I still had support from my supervisor, but that was the first time I was able to really carve out my own research ideas. Really start the learnings of how to apply for a grant as a co-investigator or as a co-principal and investigator, while having that training from my supervisor. And that was really key. I do worry, and a lot of people with PhDs go straight into research tenure track, for example, physicians or clinician scientists positions, and they're ready to go to start forming their independent program of research. But I really found that 2 years was really helpful, especially if you're able to be funded by CIHR, by SSHRC, or if you go to the US, like by the NIH and other funding mechanisms. Often these funding opportunities also give you money to actually present at conferences, gives you protected time to publish, to build your networks. And so I traveled the most I ever had in my training during my postdoc. And it really also, just gave me a bit of time to really think about what is the purpose of my program of research. And then, once I was done, I felt confident now to just start leading a program of research. So it's a great safety net as well. So I highly, highly recommend, and you actually build on your skills quite a bit as well.
Can I maybe add a little bit to that as well? I think what I've seen, what makes you successful in academia is differentiating yourself, right? So, when I started here 2015 at UCLA, I remember I had a conversation with our chair. He said, look, to be successful in academia, you need to, instead of going and digging 100 holes 1 feet deep, you need to pick one hole, dig it 100 feet deep, right? So if postdoc, it's not just doing it, right? One of the things in retrospect, right, we think about, or I think about my career path is sometimes I was maybe chasing after the 3 letters after your name, but that's not the right way to do it. You got to really invest in that degree or the time that you spend, because there's plenty of examples of folks that have similar training but never worked a day in academia or went elsewhere, and this wasn't for them. And keep in mind, you're spending precious dollars and important years of your life. So if you're going to do it, make sure you're going to use it. So if a postdoc brings you that ability to focus your research career, some people just do a master's, or some don't even, there's a lot of amazing clinicians here that I work with that don't even have an advanced research degree, right? So it's not just the 3 letters after your name or the designation, it's the time you spend. If I were to go back, I kind of had, Anne, you made that comment, you wanted to do the program in 1 year. I had the same mentality, and I tried to do too much. And if I were to go back, I would really not have that be my focus, to spend as little time as possible. Because, in my mind, I was a neurosurgeon, then I'm going to do this on the side and kind of, but and it may take 1 year, you could do it in a year, but I'm just saying, like, you really want to spend the time, and learn what you need to learn, make the connections that you need that are going to serve you right in the future, and really invest yourself, because education is the type of thing that you need to invest in to get something out of. It's not, it's not just showing up for the lectures and that's it. At the end of 2 years, you get a degree. So that's what I would say. It's not a one answer fits all, everyone now go out and do a postdoc, or everyone shouldn't. It's sort of, you need to make sure how it fits in your overall vision of how you distinguish yourself in whatever field you're in academia.
And I think that's a great way to put it and really wrap up today's panel. Is, each of you have described very unique experiences, different things that have helped you shape your research interest, that have shaped, the kinds of things that you decide to do and you work on. And a really key point to everyone listening today is, thinking about your mentors, thinking about your why, and really making sure that those are the focus of what you're doing over the next few years. And so with that, I just wanted to take this opportunity to really thank all of our panelists. By virtue of each of you being here, by sharing your diverse experiences, I think I speak for everyone in saying that, we've all really learned a lot. Thank you to everyone who's attended. Hopefully this was an interesting session and hopefully your questions got answered. And to everyone who's tuning in, I just want to encourage you, we have a second panel session next week at the same time, 4:30. Where we'll be talking more broadly about other different non-academic sort of career paths and trajectories. And so with that, I just wanted to say thank you to everyone, and a special thank you to the McMaster alumni who helped put together this panel, and to Shipra, who's been quietly sitting there, but was really the person who coordinated this entire session. So thanks, everyone. I hope this was a meaningful and useful time.